everyone, this is Dr. Denicola and another social work and human development chat. And today, my friend that I have convinced to talk to me is Dr. Brittany Wittenberg. She is a assistant professor in the School of Social Work, and she teaches in the Child and Family Studies program. And her background is not as a social worker, but as a child life specialist in the hospital setting. And so she is going to be talking with us today about her experiences in the hospital. And I'm hoping that you will be thinking about the connections to make to the course content that you've been learning about middle childhood. So, welcome, Dr. Wittenberg. Thanks for coming.
Thank you, Dr. Dinocola. I'm happy to be here.
Yeah. So why don't you tell us what do you do here in the School of Social Work?
Yes, so I am an assistant professor, just like Dr. Dinocola said, and I am in the Child and Family Studies program within the School of Social Work. And I'm also the Child Life Program Coordinator. And so my job consists of about 50% teaching and then 50% research work and writing here.
Okay. And why don't you tell us a little bit about what the Child Life Program is?
Yeah,
Yeah.
great. So a child life specialist is somebody hired, and most pediatric hospitals have child life specialists in a child life program. But it's also kind of a newer profession. We didn't start until really started exploding in children's hospitals and really being prominent in children's hospitals until the 70s and 80s. And so it still a lot of people don't know, I feel they don't know a lot about child life. So we're constantly providing education, even for the children and families that we work with in the hospitals, but also for medical staff in hospitals so that they're aware. But anyways, our main job is to try and decrease anxiety for children when they're in the hospital undergoing procedures, or also providing developmentally appropriate medical education. And so we tailor each intervention to a child's developmental level. Um,
Yeah. So why don't you tell us a little bit about your experience as a child life specialist? Because that is what you did before you became an assistant professor.
yes. So I worked as a certified child life specialist at Dell Children's Medical Center in Austin, Texas for 7 years. And I worked specifically in the surgical services unit. So I met with patients before surgery every morning. And I would, depending on their age and developmental level, I would talk to them a little bit about the anesthesia mask that they were going to breathe in to go to sleep for their surgery.
A
Um,
bunny mask?
what
Did you call it a bunny mask?
No, we called it the sleepy air mask
The
for young.
sleepy air mask. I like it.
Yeah, so that kids knew that when they breathed in it and it was connected to the sleepy air machine, right? The machine that made the sleepy air, the anesthesia machine, that it was giving them like an air medicine to help them go to sleep for their surgery or their
So
procedure.
they would understand when they were feeling different after using it and not freak
Yes.
out. Yes.
Yeah. So the kids would play with the anesthesia mask beforehand, or we'd at least offer it. Not every child wanted to play with it, but we would offer it and they could pick a flavor out so that their mask smelled good. And so I had different scents that they could smell, like bubblegum or birthday cake and things like that. And so they would um, pick one of their smells out. And then I also had a slideshow of pictures I could show them of each step of the way. So it was a psychological preparation for them so that they knew when they got to certain doors that they had to say, see you later to mom and dad, and then go with me and the surgery team or the anesthesia team to the operating room to breathe in their anesthesia mask. And so I'd show them pictures of, separate a child separating from their parent and then walking with their doctors and nurses, and then a picture of the operating room, and then a picture of the wake up room, teach them about waking up with the IV. So really trying to provide developmentally appropriate education about their experience and what they were going to experience with anesthesia and
I
what.
wish I had an adult life specialist whenever I had to go in for surgery.
So many parents would actually tell us that. Actually, we'd go in and we'd be talking, and parents would be watching our slideshow and listening to us and playing with the anesthesia mask too. And they were like, why aren't there adult life specialists in adult hospitals?" And I'm like, "Oh, there needs like the hospital environment." And like, I think you just kind of succinctly really like validated the profession and saying like, the hospital is stressful for everyone, not just kids, right? But as adults, we know how to, or we have typically some coping skills to know how to deal with it. But children, when they're so young and at different developmental levels, they don't always have the adaptive coping skills really developed or formed yet. And so our job is to try and provide education, but also to partner with the parents and empower the parents to help their child cope adaptively to the hospital situation.
Yeah, that's awesome. And as you were talking, I was thinking about medical social work and how a lot of social work in hospitals has really gravitated towards the case management
Mm,
process, which in
yes.
insurance verification and utilization reviews, that sort of thing, and how you would think that the adult specialist, the adult life specialist per se would be the social worker. And in some settings, social workers are able to do more of that for adults. But in many settings, it's not possible. And some medical social workers call it hand holding, and that are giving, social emotional support, and that there's not as much time for that unless a client is really in severe crisis.
Yeah. I would explain. So, working at a pediatric hospital or children's hospital specifically, we had three members of the psychosocial support team. So, we had the child life specialist, we had the social worker, and then we had the chaplain.
Okay.
So, I always feel, and I'm sure the other social workers would agree, that have worked in a medical environment, is that everyone is in the psychosocial team is spread too thin. You have way more patients um, than it's possible for you to see. And so you're constantly having to prioritize the patients that, are having the hardest time. In surgery where I was, we had a float social worker. So she wasn't there, she or he wasn't there every time, but I had like the specific social worker I could call that would float down from the emergency department. And so that social worker would cover surgery if I needed it, but mostly what I would do is I would make referrals specifically like for families that needed planning before the child was able to go home. Like if a child was going to be in the hospital for a few days recovering from surgery, I would call our medical social worker and I'd say, could you see this family on the inpatient unit after surgery? Check in with them. They're talking about, how they're having a hard time, paying for meals and getting transportation. And they don't have a lot of social support or family here. So I would make referrals similar to that.
Okay. So, in a similar vein, having experience working with social workers on a team like that, what would you recommend social work students to do, or what kind of knowledge do you think is important for them to be working on to prepare for a job like that?
Yeah. I think so much of preparing, like of, working in a hospital is communication and communication skills and working with your team. So like, for example, if I had a parent that was crying in the waiting room and I had like several other children to go and see for surgery, I would make a call to the chaplain or the social worker to try to make sure that like I communicated and was kind of maximizing the rest of the psychosocial support team. Um, and so I think that communication in the sense, but like also being resourceful about what other things you can offer. You can
About the resources in the community? Yeah.
Yeah, like outside of yourself. But like a lot of times, you know, only one member of the psychosocial support team is there, and I'm speaking specifically about like child life social work or chaplains. And so we were always trying to communicate and utilize each other. And I
Mhm.
hadn't really thought about like when I was preparing to become a child life specialist until I really got in the hospital in that role. So I think a lot of communication was really helpful. And also, you know, if there were ever any issues with like the medical plan, it was always great for me to call like the social worker or the chaplain, because we had that psychosocial background and that support background, which is just not what everybody has when you're talking to nurses and you're talking to doctors or surgeons. And so it's really refreshing to talk to other people that have like that psychosocial and that emotional support background.
So to be able to find providers who are part of the multidisciplinary team to kind of
Yes.
align with or to get support with, to either, refer people in the hospital to them,
Mhm.
and to, just work more effectively together when trying to advocate for clients, with medical professionals who maybe don't have that background. I imagine it takes a lot, for the psychosocial support team, to know about biology and about medical things too. I imagine it's a lot of, you have to do a lot of your own education to understand
Yes.
why certain things are done so that you can relay that
Yep.
to the families, to the kid.
Hmm. Yeah, absolutely. We learn as child life specialists, our background is in child development and family systems. It's not in medicine. And so most of what we are teaching children, we've learned directly from the nurses and physicians and doing our own research and then confirming it with the medical team to make sure that, we're providing developmentally appropriate education for in a manner for children. So yeah.
So it seems like the medical team serves, like a content expert for the
Oh,
psychosocial team. So,
yes.
right. Okay.
Yeah, and so like we would participate in morning rounds on most units. So even when I was, working or covering on inpatient units or in the emergency department, we would always do a round with the charge nurse or the physicians. And so morning rounds would be, the social worker, the child life specialist, the chaplain, and the charge nurse, the resident on call, and respiratory therapist, and we would all be together. And so the nursing and the medical team would say like, hey, can you watch out for this, this child was having some behavior issues and is really upset being here, and so and then like the social worker might fill in, well, I saw the mom yesterday and they were having a hard day, so we would really all kind of work together in that way to be informed and to provide that collaborative care.
Yeah, awesome. So, tell me a little bit about your dissertation research because it really fits and aligns with your practice, and I imagine your practice inspired your study. So, tell
Yes.
us a little bit about it.
Yeah, so I helped with the help of a parent that of a child that had surgery, and then with a nurse. And obviously, it was a huge collaborative effort with anesthesia too, but helped create a psychosocial intervention for children with autism that were undergoing surgery. So what was happening is that some children, well, I guess if I explain this a little better. So every couple days in the hospital, we would have one operating room dedicated to dental practice. And so a dentist would come, and children with autism or other special needs would need to have general anesthesia just to have their yearly teeth cleaning.
Explain that a little bit. What
Yeah.
the need for that?
So for example, um, it was often children that had probably had traumatic dental experiences in the dental office, and maybe they had been held down physically or strapped down to a chair in order to, be able to get their mouth looked at by a dentist. Um, you know, and they might have shown other challenging or aggressive behaviors. And so as a last resort, I guess, so that children could, be able to get their teeth cleaning, their annual teeth cleaning, they would block off an operating room probably 3 times a week for different dentists to come in and have their patients that had severe autism or any other developmental delays. And it was
And I know in my practice with developmental disabilities that this is a widespread issue. This is not just an issue at Dell. This is an issue
oh no.
all over the country. And unfortunately, like you said, a lot of kids don't get this needed accommodation of being in general anesthesia until they have failed other levels of care, which is very traumatic. And so I am always recommending even my adult clients who
Mhm.
have anxiety and are also on the spectrum to ask about this option with their doctors and to explain why and their
Yeah.
dentists.
Yeah.
Because
And there's,
it puts
yeah.
them at risk and the dentist at risk too of getting hurt and all of the medical staff.
And the parents. I had a patient once like headbutt his mom, because she was trying to restrain him to get some medicine down, so that he could get some medicine, and just headbutted. And she was already recovering from a previous concussion. Yeah. So, I mean, we're talking aggressive behaviors. We're talking about, staff and family members and the patient, becoming injured
Right.
from that too, and from the child too. And it's so sad because you can tell that the child has had, and I say child, right, but in my head I'm picturing like we had teenagers, we had young adults that were still coming, age
Right.
25, that
And
were.
that's pretty common for people with developmental disabilities, especially if they were diagnosed as a child, for them to continue their care at a children's hospital because other places of care don't understand their needs. And even though it's not the perfect fit in a children's hospital for young adults, sometimes it's the best option that families have.
I absolutely agree. And we would have parents that would fight, and like the doctors would want to move the family, or like transition them to adult care, but parents would fight to like keep them in pediatrics, and you can't blame
Right. And I know part of my practice has been educating
them.
physicians informally, just calling my clients and doing, continuation of care, saying, hey, I'm so and so's therapist. I know that you're their new GP. They have an existing autism diagnosis. How do you feel about that? Have you treated people before? On the spectrum and doing informal education. But what you did in your dissertation study is really interesting to make a plan, and it seems like your study involved a lot of medical education to providers too about autism, right?
Yes, so we had an educational like intervention session for each members, and thinking about surgical services. Also, you've got your preoperative like team, and then you've got your OR team, and then you've got your recovery room team. And so we
Bunch
did,
of people, yeah.
yeah, so we did a series of 3 different sessions, like one for each of those types, because oftentimes the OR nurse is the one that's experiencing the child having maybe a traumatic anesthesia induction, but they had never met the child until literally the child was brought back into the operating room, right? And so they didn't have a lot of experience with children that were awake and had
That
autism.
were awake.
Yeah, exactly. I mean, an OR nurse is very, very different. Most of the time, their interactions with patients and families are literally just the patient while they're asleep. And so it's just a very different role than, a pre-op nurse that is talking to the parent, hours before the surgery. And so, yes, provided quite a bit of education and tried to a lot of coordination and communication was very important beforehand, so that my job was to call the parent beforehand, at least a day beforehand, to try to figure out what accommodations we could make for this child. So I'll just give like a real
Yeah.
quick example. So before surgery, typically, children had to arrive 1.5 hours before they actually went into the operating room. And as you can imagine, a child with autism that is not able to eat or drink for
Or
the
any child, really. Yeah.
any child, but as you can imagine, a child with severe autism um, may act out using like more challenging behaviors in that case because they don't understand or
Or aren't able to communicate, and yeah.
because yeah, it's like the communication thing exactly. And so um, as if when I would find that out, I would ask the parent, you know, would it be helpful if y'all just came 30 minutes beforehand? And so then I would kind of go around and coordinate. And so I'd make sure that this child, they can't eat past like 10 or 11 p.m. the night before. So I would try to make them the very first schedule. Like I'd move the children with autism to the 7 a.m. start time, the earliest start time possible, so that they weren't going to be a 1 p.m. start time, still not eating from 10 p.m. before, you know. So we tried to kind of streamline that process. We tried to figure out, you know, the sedation that would be needed beforehand, what would be the least stressful for the child. I try to figure out what.
I can imagine that this involves convincing medical professionals to do these things and to uh, be open to having these accommodations. What was your experience with that?
I knew my team. I knew the members of my team that I could go to that would then be able to make it happen.
Hmm.
I worked with this team for 7 years, and so I started collecting data, let's see, like 4 to 5 years into it when I started this. So I had known this team really well. And I knew my allies, in my head, like my autism allies that I would go to. Um, and they were excited about it because in a sense, like it would just be horrible if we didn't have a plan in place. Like if it was just like fly by the seat of,
More trauma for
I
for
mean, we
the
had children
and
like,
liability for the hospital too, with using restraints and all of that.
yeah, we had children running, you know, wanting to run away, like running out of the
Hello.
unit.
Hmm.
Yeah. Yeah. And so um, it became like an important safety issue too. And it really helped, you know, the parents beforehand, just kind of understanding, especially if they had never been there before.
Right. And it's just such a more human approach to things. Everybody wants information, especially whenever you're going into something scary and new. And
Mhm.
so um, that's really exciting that you're able to implement that program and to work on finding some standardized ways that we can help
Yeah.
kids who are on the spectrum. I have one last question for you. So, what do you think that the hospital experience does for kids? I'm sure that you saw lots of chronically ill patients. Maybe you even had some that you saw more than once. Um, what do you think that that does to a child's childhood and being a kid?
Whew, big question. So at this, like when I'm thinking about that, you know, it depends the age of the child and how they're impacted, right? So for a child that is impacted with a trauma or a chronic illness in infancy, so from, you know, birth to 12 months, um, you know, one of our main issues is worried about like infant attachment. If a parent's not able to be there, you know, so we're thinking about that at their developmental level. You know, when we move to you know, ages 2 to 4, 2 to 3, and thinking about preschool years, we're very worried about children and their magical thinking and, you know, something that might say, oh, I'm going to flush your IV. They might think, oh my gosh, my IV's this
Went
IV
to
is,
the toilet?
and it's going in the toilet, right? Or, you know, we're going to move you to the floor when it's what that means, you know, is just like taking you from your surgery room to like an inpatient room, moving you to the floor. But to a child, you know, that literal thinking is like, I'm going to be put on the
I'm
floor.
gonna have to lay on the floor.
Yeah.
Yeah.
And then we're also worried about like stranger anxiety and separation anxiety, um, which, I think there's been some studies done, and like everybody you meet in the first day in a hospital, you meet like up to 70 new people.
Hmm.
You can imagine a 2-year old constantly being bombarded. It's a lot. And then, you go into school age and adolescence, and each there's going to be a different developmental impact at each of those levels.
Hmm.
And so I'm thinking like, oh gosh.
Yeah, it's different for each one. I guess the reason I asked the question is because I think that social workers who work with kids, especially, don't really realize the impact of medical trauma until they are with someone who has experienced medical trauma.
Mm-hmm.
And I think that social workers see that not only in the hospital, but in child protective work, in work in schools. And it's just an important thing to know, and that it really can affect your trajectory, your developmental trajectory, and how you think about things.
Absolutely. And like what our research tells us, there's a growing body of evidence in research in child life. And, it tells us that children like ages 6 months, kind of right when that attachment's really starting to be evident, through about age 4 is that most vulnerable for regression and developmental regression. So automatically, if there's a child on my census that is in between ages 6 months and 4 years, they're automatically prioritized
Hmm.
because of their developmental level, and how there's a chance, for example, that if a child has a traumatic medical experience and they were potty trained and doing fine, and then they had a traumatic medical experience, now they might be regressing and not able to use the bathroom, and having potty accidents, and having eating and sleeping disturbances. And so we have found that, and then with child life preparations, and child life interventions, that has helped to minimize the trauma, especially on those um, developmental priority age groups or developmental levels.
Well, thank you so much for sharing your time and your expertise with us. I lied. I have one more question. Is Hattie with you?
No, no, I think she's outside enjoying this weather.
Well, Hattie is Dr. Wittenberg's basset hound, and she's adorable. So
Yes.
we missed out this time, but maybe
Yeah.
we'll have you on another chat later and we'll get to meet
Yeah.
her.
That would be nice.
All right. Well, thank you for your time. I hope you have a great day.
Thank you. You
All
too.
right.